So I just want to give you a little bit of an update of the program and what we do with the content. Is you seeing my web browser now? Mm-hmm. Okay. So this is our homepage here, and this is on the homepage is content from all of our different programs. This is what we did last week, or this was last Wednesday's Dr. Zaman presentation. And for each one of these, we have taken kind of just the general, the general points he was making. We have his full PowerPoint. We have a full video of the session. We have resources to different data sources or articles that are relevant. And we also have an interactive transcript, which is, as you play it and it. And so nice interactive transcripts to help you, if you want to zero in on a particular quote, you can find it there. These transcripts are really, really good. They are not perfect. Every once in a while, when I've gone back just to double check a quote, there might've been like one word slightly tweaked off. But I think you do need to double check them, but it's really easy to do so to the actual audio. A couple things on upcoming programs. Tomorrow on an entirely different topic on trade, global trade issues. We have a session on how the government will be enforcing US trade laws, including we have a former assistant commissioner of the US Customs and Border Protection. And then today is the last day to apply for the accountability journalism program, which will start at the end of April and go for 8 weeks, once a week. It's investigative and accountability reporting with a big focus on how to track all the stimulus money. So anybody who works for your news organization that covers state politics, federal spending, federal politics, the PPP program, COVID relief, anything like that, or just general investigative reporting, we cover all of those. We'll be covering all of those in this program. So that's what's coming up. The deadline on the accountability program is tonight. So, the application is not that difficult, but shoot it to your colleagues and friends in the business, and we are just trying to build a good class for tonight. With that, I will turn it to our first speaker of the day. Dr. Wilson M. Compton is the Deputy Director of the National Institute on Drug Abuse, which is part of the National Institutes of Health. NIDA supports most of the world's research on the health aspects of drug abuse and addiction related to preventing drug abuse, treating addiction, and addressing the serious health consequences of drug abuse. He previously served as director of NIDA's Division of Epidemiology, Services, and Prevention Research. And before that, he was on the faculty in the Department of Psychiatry at Washington University of St. Louis, and he studied at Amherst College, and his medical education was at WashU. So Dr. Compton, we have him until noon. He's got a presentation, and we'll have plenty of time for questions. He's got a lot of ground to cover. So I'm going to turn it over to Dr. Compton and say welcome and thank you for coming.
It's my pleasure to join you. The last time I did this, I think we were in person in San Diego, if I remember correctly.
Exactly, yep.
I've done this a couple other times, and it's always a pleasure to meet with the journalists that are represented today in this virtual room. I'm going to go through this material quickly because the most important part is a chance to interact with you and address the questions you may have. But certainly you're welcome to all of these slides and materials. And if you have any follow-up questions about what I present or what I gloss over too quickly, feel free to follow up with me. While I'm mostly going to focus on the overdose crisis and the relationship to opioids, I'm going to talk at least a little bit about vaping and cannabis as other key public health issues, particularly knowing that you just had a session on cannabis and psychosis. I will go through that very quickly, but just highlight a couple things you might not have heard already. Well, let's get into it. Our general focus at the National Institute on Drug Abuse is to remind people that drug use and drug addiction are due to an interaction between our innate biology, think about our genes and our genetic makeup, we do know that these behaviors run in families and have a genetic background, but it's not all about genes. It's about how our genetic makeup interacts with the environment. And when you think about the environment, this is also where we intervene, whether that's with treatment or with prevention activities or with policies. Those can have a major impact by changing the early childhood environment, neighborhood factors, family factors, even policies and laws are part of the environment. And that's how we can influence this trajectory into addiction. Even as we're trying to understand more about the biology, we have ways to intervene already. As if that weren't complicated enough, we need to think about the biology and the environment as they intersect with age and developmental processes, because an intervention for early childhood won't be the same as one we use for young adults or adults, for example. And that is, and the revolution in understanding brain development has helped us have a greater understanding of these trajectories and pathways. All right, so that's by way of background, sort of the overall concept that will influence the way I think about these issues. Let's talk about the overdose crisis. You all are well aware that the overdose crisis has been an emerging epidemic over the last at least 20 years, but some would say over the last 40 years in the US. It's gained attention for at least the last decade or a little longer, and has emerged first as a problem related to the prescription opioids. Notice that those increased, the deaths related to the typical prescription opioids increased markedly in the first part of this century, but have leveled off in the last 10 years. Heroin came in as a secondary issue in terms of the overdose crisis and really picked up anyway around 2008 and 9 and increased rapidly. But the last few years have seen a leveling off of heroin deaths as we have seen synthetic opioids other than methadone. Notice that I put fentanyl in quotes because this is not the medically used fentanyl in surgeries or in anesthesia or in end-of-life care, but is illicit fentanyl. So in some ways, it's much closer to the heroin market. What we have also seen in the last, particularly the last 5 years, has been that deaths associated with stimulants have markedly increased as well. Some see this as a fourth wave, and certainly these are not separate concepts because a lot of the stimulant-related deaths include an overlap between stimulants and the synthetic opioids like fentanyl, where cocaine or methamphetamine may be co-ingested with these substances or maybe inadvertently used. In other words, the drug supply for illicit drugs like cocaine and methamphetamine may be contaminated with opioids, and so the poisonings may be related to that contamination. There's a lot that we understand about the dynamics of this crisis. I think economics influence all the phases, but I particularly highlight for you the economics in terms of the illicit fentanyl because it's so relatively inexpensive to manufacture, and the potency also contributes to this. Not only is it inexpensive, but because it's so potent, a very small amount, which makes smuggling and transportation much more feasible, can produce both a product that can be sold on the streets all across the US or in households across the US, but also cause the devastation and overdose. I highlight this book by Sam Quinones because it reminds us that it's not just the substances, but it's also the way these substances are marketed and sold, that the ready number of persons who are likely to shift into illicit markets, meaning who's the market for illicit opioids, has expanded tremendously in the US as the use of the prescription pills meant that there were millions of people who were potential customers for the illicit markets. And that's the way illicit opioids have been sold in the US, and the places around the US where they're sold has shifted in the last decade as well. It's not just the overdose deaths, though. Just a quick reminder that we have such issues as neonatal opioid withdrawal, as well as infectious diseases like hepatitis C and HIV that have increased in the last decade or 2 decades in conjunction with this increasing opioid set of issues and the increasing overdose deaths. But what can we do about this? Well, something that hasn't gotten as much attention as I think it deserves, as you can tell from the publication that I highlight here, is that universal prevention, starting with middle school, particularly the family-based or social skills-based interventions, have been shown by researchers like Dick Spoth and colleagues to have a long-lasting protective impact on preventing the use of substances and reducing the use of substances as youth emerge into adulthood. And this has applied to prescription opioids, as well as in this case, I highlight for you some old research showing that it can have an impact on methamphetamine onset as well. So some of our tried and true universal prevention approaches can have an impact on these emerging crises, even when that wasn't the original purpose of these interventions. Yet we don't see these prevention interventions widely implemented across the US. When we think about policy approaches and practice changes, one of the major interventions was the release by the CDC 5 years ago of their prescribing guidelines for opioids. This is a major impact on practice and was part of what I think of kind of unselling the excess prescribing of opioids. Unfortunately, one of the complications of this guideline and other practice changes has been that clinicians became afraid of prescribing opioids and sometimes would just say, all right, we're just going to not prescribe them at all. That led to a second set of issues, whereas if we abruptly discontinue opioids for a patient who's been taking them long-term, whether that's medically taking them or taking them because of illicit drug use, the consequences are significant. Patients suffer significant withdrawal symptoms. So the morbidity associated with an abrupt discontinuation of opioids has generated some recent attention. And so we had to follow up with this additional guidance, basically with a very simple message of don't abruptly stop opioids. Make sure that you taper them carefully and methodically or substitute with other agents. In addition to changing prescribing practices, we think about saving lives acutely with naloxone distribution. NIDA has been particularly involved in this in helping to develop the intranasal formulation, which has made it much easier for the public to administer naloxone in real-world field settings. The final sort of leg of our major approaches in terms of sort of prescription changes of saving lives acutely has been to do a better job of getting medications for opioid use disorder out into the community for the patients that can benefit from them. There are a couple of problems with this though. They're not widely used, so we still have a lot of room for improvement in terms of the utilization of these life-saving medications. And even when they're used appropriately, relapse rates are very high. So we need to do a better job of developing new approaches for these conditions. So what have we been doing about this at the National Institute on Drug Abuse? We've been focusing on, particularly on implementation issues. So for instance, following the publication of a seminal report about starting buprenorphine in emergency departments a few years ago, we've been working on multi-site trials and implementation strategies with emergency departments. Criminal justice settings have been another place where our patients are seen. And so making sure that we get medications for opioid use disorder for persons on probation and parole, or as they're re-entering the community after incarceration is key. And for those who are incarcerated, particularly short term, so in jails, what can we do to make sure that people stay on their medications while they're incarcerated or start on them before they're released back to the community? Those have been some of our key goals of our justice research program. We've also been conducting some of the head-to-head studies. It's unusual to compare active medications in the addiction field. And so we supported a study that compared the extended release naltrexone, that's the injectable long-acting opioid blocking agent naltrexone, to buprenorphine, showing that buprenorphine was, in terms of the a priori administration, was more effective overall. But if you look, those lines look quite parallel. So it was difficult to get people onto the extended release naltrexone, but once they were on it, they seemed to do about as well as patients on buprenorphine, to help clinicians make that choice about what medication should they prescribe for their patients with opioid use disorder. Of course, we've been extraordinarily pleased with the largesse from Congress under the Helping End Addiction Long-Term Initiative, which is $500 million a year starting in 2018. has led to a large number of programs focused on enhancing pain treatment. After all, if what got us into this mess was inappropriate use of opioids for the treatment of pain, what can we do to do a better job of treating pain and avoid the excess and inappropriate use of opioids? The second part, which is more where the National Institute on Drug Abuse is involved, is how can we improve treatments for misuse and addiction? So can we address issues related to better interventions for acute opioid overdoses, as well as what can we do to develop better prevention and treatment approaches? Now that's my quick version of some of the issues related to opioids. I want to talk about two other major themes, then we'll come to how there's an intersection of COVID with the opioid crisis as well. Vaping represents another major public health issue. It's surprised us since about 2015 when we started seeing marked increases in the rates of vaping products, e-cigarettes, that youth have been using e-cigarettes much more than combustible cigarettes for the last few years, with millions of middle and high school students exposed to these potentially toxic and addictive products each year in the US. In 2020, we had some difficulty with data collection in 2020, as you can imagine, with the pandemic influencing and making it hard to do research with the public, but we were able to obtain data through our colleagues at the University of Michigan, who have a long-standing study of 8th grade, 10th grade, and 12th grade students. And they were able to release data from the January through March period of 2020. And in this study, it showed that vaping of nicotine or any vaping remained at unacceptably high levels, but at least it no longer was increasing in 2020. The daily vaping held steady. Also, youth started perceiving it as a little bit more risky, and so some of the public health messaging was getting across to youth. Our concern, of course, is that vaping of nicotine products may lead to use of combustible cigarettes. And while we're not 100% sure of this, these are not natural experiments, but longitudinal follow-up of youth. And some of these youth are ones who would have transitioned to cigarettes anyway. But there's a concern that early exposure to nicotine may accelerate that transition to combustible cigarettes. The other key issue that we struggle with youth is that the messaging is very complicated here. Because for smokers, it's quite clear that e-cigarette products have less harmful chemicals than a conventional cigarette. But less does not mean none. So safer is not the same as safe. And that's been a subtle message that I've tried to explain by using analogies like, if you jump off a 10-story balcony, that's almost certainly going to be fatal. If you jump off a second-story balcony, that's not safe. It can be fatal. It certainly may injure you. And so safer is not the same as safe. But how to explain that to youth in a way that has a meaningful impact on their behavior has been a real difficulty for public health officials.
Dr. Compton, just a quick question on definitions. On that last slide, the numbers in red on the right, how do I interpret those numbers?
It's basically a ratio of conventional cigarettes to e-cigarettes in terms of the levels of formaldehyde, acetaldehyde, or carcinogens like acrolein, and some of the others. Cadmium and nickel are the heavy metals that are present in cigarettes in particular. They're quite low in e-cigarettes, but it's not zero. And so that's what I like to point out is e-cigarettes are not like puffing air. There are harmful chemicals in them. For a confirmed smoker, as a clinician, I'm going, all right, if I can't help you quit using other products, e-cigarettes seem a reasonable thing to consider as an alternative. But safer is not the same as safe. And we'd like you to breathe air rather than even be putting these low levels of harmful chemicals in your lungs. Does that make sense, Chris?
Yes, thank you.
Okay. All right, I'm going to zip through cannabis. This has been, of course, a major theme for public health and policy. This is a very commonly used substance. What's been startling to me is how many people are initiating use of cannabis, and 3.5 million Americans using it for the first time in 2019. That's almost double the rates of initiation that we saw just 5, 7, or 10 years ago. So a lot more people are picking up cannabis. And while, of course, the onset is primarily in youth and very young adults, but we are seeing older adults, meaning over age 26 and sometimes even middle age, picking up cannabis for the first time, as we see a major shift in the policies related to it. Cannabis use has been increasing in adults, either young adults or the older adults. But interestingly, in the youngest group, there's a slight increase in 2019, but in general, these rates have been flat. And so that's some good news in that we haven't seen an increase in the 12 to 17-year-olds. I did some work recently to show that this use by adults, though, may be concerning because when parents use cannabis, whether that's a mother or a father, we see higher rates of either cannabis, of course, cannabis use, but also tobacco, alcohol, and opioid use in their offspring. And that's true whether the parents used it previously, but particularly true if they're using it currently, so at some point during the last year. So it makes us somewhat concerned about adults, particularly when they have youth in their household use of these substances. You're well aware that cannabis laws have been changing. I have this slide from just a few weeks ago, and I already have to change it because of changes in the laws in New York and Virginia. I think it was last week and the week before that those laws have changed. So the changing policy environment and legal environment plays a major role in this. And we've been funding research through our grant program to help understand the impact of these shifting cannabis laws, whether that's medical marijuana, now going back 25 years with the first example in California, or recreational cannabis, of course, well known in Colorado, California, but now in many parts of the country. This matters. We've seen shifts in what kind of products are being used. So there's some interesting data coming out of Colorado reminding us that cannabis products, and I highlight for you the lower bars that are showing concentrates representing a much larger proportion of the sales and of the use. We actually don't have the public health information about use of all of these different products in as much detail as we would like on a national level. But we are now starting to see state level data help us understand these shifting patterns. This is part of a general trend of increasing THC potency. This is data from police seized cannabis products. So this would be illegal cannabis seized and then analyzed, documenting though a 4 to 5-fold increase in the potency over the last 20 to 25 years, and a corresponding decrease in the level of CBD in cannabis. So while we're mostly focusing on high THC and those concentrates, by their name, reminds us that THC can be extremely potent in those concentrates. But it may also be important that CBD is quite low in these products as well, because that may have an impact on the negative consequences of use of them. So I've seen some interesting data coming out of San Diego, reminding us that there's been a shift in the acute consequences of cannabis use, at least in that jurisdiction, where we've seen a marked increase in emergency department diagnoses related to psychosis, panic attacks, hyperemesis, or what I heard one emergency department physician call scromiting, screaming and vomiting, because they're so miserable while they're vomiting. And that is a syndrome of heavy cannabis exposure over time. But some of this may also be acute cannabis exposure and essentially a overdose symptoms where acute panic and sometimes frank psychosis can be due to acute cannabis overdose. Long-term outcomes, of course, as a psychiatrist, this is something that is very concerning to me. And we see an increase in young adult depression, anxiety, and suicidality in those that, particularly those that use marijuana heavily during their teen years. That's what these longitudinal studies would suggest. And you all have been had a session on psychosis, but I just highlight for you that while it's early onset of cannabis associated with these very negative outcomes, but particularly the high potency cannabis seems to be associated with these negative outcomes as well. We'd like to understand what cannabis is doing to the brain, and there are multiple studies showing altered brain structure and function. But there's a problem with these studies. First off, not all the studies find these same differences. And in fact, there's quite a disparity across the different studies in terms of structures within the brain. So what we've done is we've launched a very large scale study called the Adolescent Brain Cognitive Development Study that is following about 12,000 children. And we started with 9 and 10-year-olds, meaning that's before they're exposed to cannabis. Now, of course, some of them may have had prenatal exposures to various substances. Some of them will of course come from a variety of backgrounds. So we do very careful, thorough assessments at baseline to understand their pre-existing situation, including an MRI scan at ages 9 and 10. Now, this study is already in the middle of its follow-up, first major follow-up at now ages about 12. And so we're beginning to get a glimpse of what's happening to the developing brain, either with early exposure, and I'll come back to this in a minute, but we think this study will help address a major concern about the existing data, which is most of the studies look at adults and look at cannabis user versus not cannabis users and look at differences. Well, the differences might have been there before, might have helped explain why they used cannabis to begin with, or why they had those negative outcomes. So this study will help us look at pre-existing brain structure and function in addition to other environmental factors. So I'll be happy to entertain a few questions about the methods of this if you'd like. Now, let me end by spending a few minutes talking about the intersection of our latest public health crisis, the COVID pandemic and addiction. We've recognized, and my director, Dr. Nora Volkoff, has published extensively on the challenges during the COVID-19 pandemic, whether these are the stress and stigma that are notorious factors in leading to relapse and problems with substances. There may be limited access to the medications that it can be life-saving. Also, social distancing can be both a stress and it may have a direct impact on overdose. If you're alone when you overdose, you're much more likely to have a fatal overdose. Makes sense. There's no one there to rescue you and resuscitate you. I also want to highlight for you a fascinating study from a couple of years ago that was a really stark reminder that even in our rodent animal models, drugs are not preferred when social reward is possible. So in this case, a rat will choose playing with another creature over heroin. But you can manipulate that and change that. So if the social reward is punished, if there are negative aspects to it, they will choose drugs. So drug use is not inevitable in comparison to social factors. I think this may be a clue about why many of our drug treatments include a major aspect of social interaction as a substitute for drugs. All right, so that's by way of sort of context and background. We've seen from data like the Millennium Health Report and a report by Niles and colleagues that drug use has increased during the pandemic. We started seeing particular increases in fentanyl positivity, but it wasn't just fentanyl, it was also cocaine, methamphetamine, showed increases in these data sets. Dr. Volkoff did some very interesting work looking at very large scale health records showing an association of substance use disorders generally, but particular opioid use disorder with both having a COVID diagnosis and the most negative outcomes associated with it. We see more COVID diagnoses among teens and young adults who vape and smoke cigarettes. So this is just some of the data to remind us that behaviors that influence lung health can have a negative outcome on essentially a lung-related illness, which is what COVID-19 is. We've seen some important changes in overdose deaths now, so let me walk you through some of the recent data. We saw a peak in overdose deaths in November 2017, a low point, a very modest, but it's certainly a leveling out over about a 14-month period of time. But notice a market increase again over the last 15 months with an acceleration in the most recent data. CDC issued a health alert advisory based on the data from the early part of the pandemic, showing a market increase in deaths, particularly those related to the synthetic opioids in the west part of the country. So market increases in the fentanyl-related deaths during the early part of the pandemic. Now, in addition to the shifts in drug use and drug-related outcomes, there's a major change in health care delivery, particularly in the early part of the pandemic, as essentially all in-person services stopped unless they were for emergencies or absolutely essential care. Major increased use in telemedicine. There was some major policy changes allowing greater reimbursement for telemedicine, as well as a relaxation of the requirements for in-person services related to either buprenorphine or methadone treatment. So expansion of take-home medications for methadone and ability to begin patients on buprenorphine without an in-person physical exam. That's a major change in how we conduct these services. We did see some changes in prescribing. A report from our colleagues at CDC showed that particularly naltrexone, the extended release naltrexone, which requires an in-person or at least a physical visit to get the injection each month, showed a reduction during the early part of the pandemic. And I've got just a smattering of other data that showed that there are some changes based on the social changes. Interestingly, this report around drinking showed that those that moved from their peers back to their parents did show some reductions in drinking once they moved back home. It doesn't totally shock me. Parents do provide some supervision, so their college age youth that moved back in showed a change. On the other hand, if they were still living with the parents the whole time, there was no major change. And those that lived with their peers or stayed with their parents actually increased a little bit. So it's moving from your peer living back to parents was somewhat protected, but otherwise there was some evidence that perhaps the stress of the pandemic caused an increase in alcohol consumption. Some changes in availability of vaping products. So at least based on self-report, they saw some reductions in vaping during the pandemic. Now, there's some interesting and tantalizing preliminary data coming from our ABCD, that's the Adolescent Brain Cognitive Development Study. Of course, during these periods of development from ages 11 to 14, this is when we see drug use beginning. So this is just a baseline showing that the prevalence of substance use increases during early adolescence. That's not novel. We've known that for a long time, that this is the period of risk. But we've seen an interesting issue during the pandemic where any substance use has been pretty well level, but a slight decline in alcohol use, but an increase in tobacco use. Now, I can't completely explain these patterns. So we're waiting for more complete data coming out of the ABCD study and others to look at what's going on during these major change in the social environment. In some ways, greater supervision by parents of their youth because they're in the home a whole lot more than they used to be. On the other hand, the stress and the changes are extraordinary. So this is unpublished data from Dr. Pelham, but at least a tantalizing glimpse into the intersecting social environment and substance use in a very high-risk period in youth development. Now, in addition to highlighting some of the data that we are able to obtain, I just want to end by mentioning that these studies had had trouble collecting data during the pandemic. And like everybody else, we show resilience and we figured out how to adopt and adapt to them. So while our Monitoring the Future was our major NIDA-funded study of Adolescent, ceased collection in March of 2020. And so it interrupted the last about 2/3 of that large-scale data collection, or 3/4 of it. But this year, they're back in the field using online or in-person where possible, but mostly online data collection in a large sample of schools. So we're hopeful that they will have a large amount of data to report from 2021 in the next few months. We have a large-scale population assessment of tobacco and health. It's a nationally representative cohort of about 45,000 persons, ages 12 and older. And of course, they shifted as of March 20. They stopped data collection and we resumed it rather than in person, but we started with using telephone collection, data collection in July. And that's how we're continuing at the present time. We hope to get back to doing in-person interviews shortly. The ABCD study, as I highlighted, stopped their in-person data collection in March, and they had a lot more to go in this 2-year follow-up. And they transitioned to telephone and online data collection for many of the measures, but you can't do an MRI scan on the telephone or in a Zoom call. So they're just now getting back up to resume in-person visits for that neuroimaging as we are developing safety protocols that allow this to be done across the country. So just a couple of take-home messages. The overdose epidemic has accelerated as best we can tell during this COVID public health emergency. What I can't completely separate though is how much of this is a continuation of that acceleration that we were seeing from fentanyl being marketed and sold in new parts of the country, as well as the social impacts of the pandemic intersecting with the overdose risks. And of course, a broad theme of my presentation has been the importance of science to offer solutions to these public health crises, whether these are the shorter term immediate implementation of what we know works, or the testing and development of longer term solutions and basic science to come up with very novel ways to address these issues. And with that, I'll open it up to questions.
Okay.
I'm going to stop sharing, but I can reopen my slides anytime you like.
Yeah. So Barbara, you had a question in the chat. Why don't you just go ahead and ask that and other folks can raise their hands?
Yeah. Do you think that the pandemic has helped make treatment more accessible? And do you think this practice will continue? Other people are being treated via, telephone or video conferencing, and they're prescribing take-home medications. It just seems like, for some people, at least in the Rhode Island area, seem to believe it's more accessible to them now.
Well, we certainly have been conducting research and supporting investigators to address that very question. So I like the way you ask it, which is, what do I think? So I'm allowed to have opinions about this and thoughts about it. I certainly am impressed that we're hearing from some of the large practices around the country that things like no-show rates have been reduced for behavioral health conditions. So some of my colleagues that have very large-scale clinics and programs around the country are saying they're surprised that they have more people showing up for their appointments when they're done virtually. Makes sense to me as a clinician or as a patient. I don't know about you, but going to a doctor's office doesn't just take the half hour or hour when you're actually in the office, but it takes many hours. You got to get in the car or get on public transportation, go to the office, wait, and then get in to see the clinician. So it's a major investment of time and effort for a patient. And reducing those barriers are something that we want to learn from so we can implement those that work. On the other hand, when I start somebody on buprenorphine and I haven't done a physical exam, do I lose anything in that process? I'm not sure. So there is the potential for concern in some of the practice changes, and we want to learn what helps and what is less beneficial to make sure we fine tune this. Also, there's a question about a lot of these practices were implemented using the public health emergency as the justification. Can they be implemented long-term without a change in legislation? I'm not sure. So that's a question for the Office of General Counsel within HHS to help us, Health and Human Services in the federal government and state governments, to make sure we have the appropriate language in the legislation to allow us to consider implementing these practices if they're beneficial long-term. I have been intrigued that while I automatically assume that means patients are being seen on Zoom or FaceTime or some other video technology, that actually hasn't been the case. And a lot of it is using a telephone-based care, which I find reassuring because there are many people in rural parts of the country and others that actually don't have as much access to broadband that allows us to have visual contact with patients. So I'm glad that it includes traditional telemedicine as well.
Okay, so just FYI that Barbara is from NBC 10 in Providence. And so when you ask your question, tell Dr. Compton where you are from. So we have several questions. We'll have Kyle, Will, Andrea, Brian, Danielle, Alva, Almain, Stephen, and Nadia. We'll go.
I'll try to keep my answers short.
Yeah, so we have 20 minutes. So, we have plenty of time, but yeah, answers on the shorter side. We'll go to Kyle first.
Hi, sir. Thanks for making time. I'm with Gray Television's DC Bureau. Got a couple of questions, but I wanted to start following up on the buprenorphine question. I know I've been in cities where there's a debate over whether buprenorphine that's been picked up as street bupe, as they've called it, has been released by the police departments. I was curious what you make of the phenomenon of street buprenorphine and what that says about the availability of medication-assisted treatment.
Well, some of that will be a product of it is more readily available. We see the number of prescribers and the number of prescriptions for buprenorphine increasing over the last few years. So I'm not surprised to see more of it appearing in the street. This is an abusable substance. It can produce an intoxication. On the other hand, we also hear reports from patients that when they misuse it, they're often using it to treat their own withdrawal symptoms. So I'm hopeful that some of that will translate into people realizing that it may be helpful to them and coming in for long-term care, which is what we see where the benefits occur.
And quickly, if I can have a follow-up here, you also talked about the education amongst the youth. There were a lot of studies that came out following DARE that suggested it might have had the opposite of its intended effect. What's been the difference between that program and some of its failures and some of the current programs that are making headway on this based on the data?
Well, some of the reasons we learned that the early DARE programs were not effective and may have had iatrogenic negative consequences because of careful longitudinal and randomized clinical trials of them. So the studies I highlighted for you, like the studies using the Strengthening Families Program 10 to 14, that's Dick Spote's program and colleagues that I used as one example, have had that same rigorous study showing in multiple evaluations a positive impact on youth drug use. That's why we stand behind them strongly. But we continue to collect data, and if we're proven wrong in the future, we will come up with new and better ideas.
Thank you.
Okay, next we'll go to Will.
Hi there, this is Will Stone. I'm a reporter working for NPR, mostly in Kaiser Health News, based in Seattle. And I'm just interested in, research around cannabis. I've covered this a bit. You're talking about the adolescent kind of longitudinal study, but are you, I hear from a lot of people who say, we just need more research in general about cannabis, what it can be used for, what it can't be. And I know NIDA is kind of involved in that, is my understanding. And I wonder, do you think that we should be trying to have more FDA-approved kind of studies, authorized studies, to look at the possible benefits of cannabis for something like PTSD or these other conditions where there's interest in?
Absolutely. There are major impediments to research of the use of cannabis for health conditions. There are also major impediments even to looking at the consequences of cannabis use. For instance, you're not allowed to use our research dollars to directly study the cannabis that comes in the dispensaries right down the street or possibly down the hallway from where you're operating in Washington State. If you're not allowed to engage in illegal behavior using our research funds, and purchase of cannabis in Washington State is illegal from a federal perspective. So we aren't able to understand what's being dispensed in those dispensaries, and that's a major impediment to research. If you want to study using federal dollars, the impact of cannabis on health conditions, you need to use the marijuana that's grown out of the University of Mississippi, which will be, of course, somewhat limited and not necessarily the same as what people are using from the dispensaries. So we think there's a potential need for changes in the a way we conduct research in this country.
Thank you.
Next up is Andrea.
Sorry about that. I had one question, but now I have another, which is a follow-on of that. Do you think we will see the Biden administration then move to reschedule cannabis so that it could be studied more widely and, more would be known?
Well, I think it would be useful for you all to speak to the Office of National Drug Control Policy and the policymakers about that. My job at NIH is to live within our current system, to point out the strengths and weaknesses, and to conduct research that will allow rigorous information to inform those discussions.
But it sounds like you would like to see barriers cleared so that more research could happen.
Our agency is on the record in multiple congressional testimonies by Dr. Volkoff, encouraging a change to allow access to cannabis as it's being used by the public for research.
Thank you.
Brian, do you still have a question? Your hand is down now.
Sure, I'll ask. Can you hear me?
Yep.
Perfectly.
Dr. Compton, one of the things that's really interesting to me in working on opioid-related matters is just how little basic real-time data there is around the country in terms of overdose statistics, tracking where these different, outbreaks occur. A lot of the research you're talking about is fascinating, but it's fairly sort of granular and, specific, whereas it often seems like the experts I'm speaking to are just flying blind in terms of where people are dying, which demographic groups are being hit hardest in any particular city. And I guess my question is, why so long into these various drug epidemics do we have so little ability to track this in real time, to know where outbreaks are occurring, which drugs are a concern in which cities, that kind of thing? It seems remarkably broken at that level.
Well, I will point out that there is a certain length of time that it takes to conduct the analyses of body fluids to determine what's in them when somebody dies. So some of this is kind of an inherent weakness in laboratory medicine of you can get a good idea that there was an overdose quite rapidly, but in terms of knowing exactly what substances are present in stomach contents, in serum, in urine from a decedent, that will take weeks in many labs. There certainly can be ways to speed that up. And so some of the work that CDC is doing, and we certainly support this, has been to try to speed up that inherent slowness. Now, that said, that's a matter of weeks. That's not the months or a full year, a year and a half that it takes to have the final data. We rely on local jurisdictions to submit their data to the states, and then the states to submit it to CDC, where it's compiled and then presented for us to use. CDC has shifted, the National Center for Health Statistics has made major strides in improving the speed with which we see overdose death data. For instance, what I presented to you are data up through August of last year, and I bet we'll see September. I thought we might have seen it at the end of last week, but I looked last night and I didn't see September. But they're about 6 to 7 months with the provisional data that are quite close to the final numbers. So that is a major improvement. But again, that's still a few months in the rearview mirror. And I agree with you. We need to look for novel ways to improve our data collection of what are fundamentally illicit and hidden behaviors. And so that's part of the problem, is how do we find these hidden behaviors in a more rapid manner?
Thank you.
All right.
I have other thoughts about this, but I think if you wanted to do some follow-up discussion around it, I'd be happy to talk more at some point.
All right, I'll give you a shout. I'm curious about that. Thanks.
All right, next up, Alva Omwan.
Muted. It's Alva Omwa. I just wanted to follow up, Dr. Compton, on something you mentioned about the two different kinds of fentanyl out there. You mentioned there's a fentanyl for surgery and a fentanyl for the heroin market. Can you hear me?
Yes, you're a little soft, but I can hear you.
Oh, okay.
I just turned my volume up.
Okay, great. And I'm just sort of curious about how that gets distinguished in, what are the, I guess this is the first time that I'm realizing that there's an actual difference between sort of fentanyl for surgery and fentanyl for hair. Like, what is the main source that fentanyl comes from for it to have these two distinctions? I guess I wasn't clear on that.
Well, fundamentally, they can be identical. So whether it's manufactured in by the pharmaceutical industry and used by an anesthesiologist for surgery, it may be exactly the same chemical that's produced in a factory in China and then shipped into our illicit drug market. But the way that it is used will be quite different, and the way it's marketed will be quite different. So it can be, we do see fentanyl diverted from legitimate medical sources. You'll see fentanyl is sometimes used in a patch. So it may be used for end-of-life care by hospices. And you'll see after somebody's died that sometimes someone will come and steal the leftover medications. We see occasionally it's diverted out of hospitals, but fentanyl is not. What's been quite clear is that the rates of fentanyl prescribing have not changed in a major way. And yet we see police seizures of fentanyl corresponding to the high rates of overdose deaths in many jurisdictions around the country. Also, it's not fentanyl is a single chemical entity, but you've heard of carfentanil and other chemical relatives of the fentanyl compound. Those are not used for medical purposes. So if that's what's detected in a decedent, we can absolutely guarantee that came from an illicit market. But it's the combination of the law enforcement data as well as the clinical data from a medical examiner that helps us understand that this is mostly the illicit marketed fentanyl. But that's one of the complexities here, is that it's the same chemical at its root.
I just have one more follow-up question. So are we to assume that most fentanyl comes from China, or does the US also manufacture fentanyl if it's a manufacturer? Is it something that's easy for people to produce?
It's not easy to produce. It requires unlike methamphetamine that can be synthesized quite readily in sort of a bathtub version, as made well known by recent television shows, the fentanyl requires a full-scale chemical manufacturing facility.
Okay.
Thank you very much.
It's why there's an intersection of international diplomacy, helping to get the Chinese government, which they have been in recent years, to crack down and reduce the production of fentanyl by factories in China. And I would encourage you to speak to the law enforcement officials at Drug Enforcement Agency and others for more details about this, because pretty soon I'm going to go a little too far out on a limb and beyond what I'm aware of as a clinician scientist here.
But isn't it easy? Isn't it easy to just get that compound and create it in the US? Why is there so much of a focus on China?
It's not easy to manufacture. It requires it would require somebody's lab to be set up to do this. And we just don't see that much in the US. It's not impossible, but we haven't seen that to be done. I am hearing reports from colleagues in law enforcement that part of what we are seeing is the setup of some of these laboratories in other countries. And so it may not just be the Far East that sells it to us in the future.
Okay, so we still have a handful of questions. We'll try to get as many in, but keep questions and answers tight. We'll go to Stephen right now.
Thank you, Dr. Compton. My name is Stephen Johnson. I write for Modern Healthcare magazine. My question was in terms of treatment there. I know there's been there's been research for years in terms of best types of treatment. And as I understand, what's considered the gold standard is medication-assisted treatment with counseling. I'm just wondering why that method is not more prevalent in the United States. Why we still have a huge prevalence of abstinence-based therapies when it comes to addiction treatment.
How long do you think it takes to implement evidence-based approaches in any area of health, or frankly, any area of behavior? It doesn't happen overnight. We have a large infrastructure. You need to change education, you need to change backgrounds, and so that doesn't happen overnight. That's my short version of a complex question. Also, the fact that these medications are not perfectly effective is an issue. There's a lot of people that fall off and relapse despite use of these medications. And so while they are effective, they're not perfect, and we have a long way to go towards improving them. And those failures, whether that's even when it is beneficial on average, can be part of the reason that it is not more widely accepted.
Thank you.
Next up, Nadia.
Hi, Dr. Compton. It's Nadia Kunang. I'm a producer with CNN. I had two questions in regards to the cannabis data. One, in some of the surveys, like the Monitoring for the Future survey, I'm just curious if the questions in regards to cannabis on illicit marijuana use in general, so potentially incorporating, CBD, since that's been legalized. And then to follow up on that, I'm curious if there's any research that's been looking at how CBD use may potentially, or not, if there's been any associations, I guess, between CBD use and for illicit marijuana or drug use.
Well, the whole CBD issue is, of course, extremely complicated. The Farm Bill added complexity to this, and is it CBD? Is it CBD plus relatives of THC? This has gotten very fascinating but complicated that I can't answer in a quick version. We're very keen to understand the potential role of CBD in either ameliorating some of the negative impacts of high THC, or perhaps as a treatment for opioid use disorder. And there's some research being conducted right now on that question, and possibly in addressing cannabis use disorder or addiction to cannabis. These are ongoing research questions, and I don't have a specific answer yet, but it's certainly one we're interested in exploring.
All right, next up, Christine.
Hi, I'm Christine Herman with Illinois Public Media. My question is just regarding the rat study you mentioned that showed when rats are given the option between heroin and a social interaction, like they can be satisfied with the social interaction and even take it over the choice of the heroin. I mean, with the pandemic and all the public health guidance saying social distancing, I wonder if, like going forward, if the messaging for people with an opioid use disorder, if the risk of the coronavirus is less significant than the risk of potentially overdose death, and if somehow the public health messaging needs to be more nuanced going forward to help people weigh the risks of the decisions they're making to try to protect themselves from the virus versus protect themselves from the negative consequences of losing that social interaction, that support, and potentially, losing their lives. I'm sorry, that's a very jumbled question. I'm trying to make it quick, but I think you probably understand what I'm trying to ask.
Well, I think we're not going to be able to answer all of those variables at the same time. And by the time we have some answers, we will be hopefully long into vaccination of the large population. What I have been pleased to see and excited to see is CDC add substance use disorders to the priority conditions for vaccination. So it's a good reminder that behavioral health conditions are part of health in general. And the risks associated with substance use disorders accelerate the risks generally from this current pandemic, as you're pointing out.
Okay, so we have Alexis next.
Hi, my name is Alexis Winook. I write for a publication called brainfacts.org. I'd like to build off a question that Kyle asked earlier about some of the education, prevention interventions for children and teens. Do you have any thoughts about what makes the programs that you're mentioning, what makes them effective or more effective than programs like DARE?
Well, we rarely have true head-to-head comparisons of them, so I'm not going to be able to answer that in any detail. I am particularly impressed by family-based approaches as ones that can strengthen families and provide the nurturing and support that teens need, as well as appropriate types of supervision and guidance that teens also need. That's the balance that parents of 2-year-olds struggle to maintain, and it's that same balance that works at the next major developmental phase, which is adolescence. And so that's at least a common feature from approaches like the Strengthening African American Families intervention that's been very interesting as it's been implemented in Georgia, or the Iowa Strengthening Families, it's now called Strengthening Family Program 10 to 14. And there's a meta-analysis of family programs that looks persuasive to me. So that's at least one clue that looks useful to my eyes. There's some real prevention experts that I would encourage you to speak to through the Society for Prevention Research that might have some additional insights.
Okay, we have 3 minutes. We have 3 questions, so we can all do the math there. Madeline is next.
Yeah, just looking at the increases of overdose deaths in US, you have a map up there. I'm with the Mountain West News Bureau, so just reporting for NPR stations throughout the Intermountain West. I see that Montana, Idaho, and Wyoming don't have data in that map with the overdose increases. I was just wondering why. I know that those states do track that data, but I don't know if that's not enough data or they just don't have to send it to the CDC or what's going on there.
I can't speak to those particular. My hunch would be that the numbers are small enough that it takes more time to accumulate them to have stable rates to be able to report changes in a relatively short period of time. But you might ask the folks at National Center for Health Statistics for a more definitive answer.
Okay, thank you.
So last question to Georgia.
Sorry. I'm Georgia Kovanas. I work at the Detroit Free Press. I had a question about fentanyl. I keep hearing from law enforcement that they're overdosing from touching it during traffic seizures and so forth. I also hear from other people that that's not true. What is the situation? How easy is it to overdose off street fentanyl if you're law enforcement or if you're just somebody who's like coming in contact with it?
Well, particularly with fentanyl itself is quite potent, but particularly some of its chemical relatives like carfentanil, where it's even about 100 times more potent than fentanyl in terms of risk of overdose death, that those might have sufficient either lung distribution, so if you breathe in enough powder, or through transdermal, meaning through the skin, might possibly be related to overdose. I think that's one of the reasons why we encourage law enforcement to have overdose remedies available routinely. Mostly they will be using it in the public to help somebody who's had an overdose to allow them to be resuscitated in a timely manner. Because we can only save you if we get the overdose remedy to you within a few minutes of when you stop breathing.
But in terms of overdosing, is it true that law enforcement people are indeed overdosing on fentanyl just by like touching it?
I don't know specifics about the reports you're describing, so I'd want to hear some more details and want to speak to the local medical examiner or the health officials to understand whether that was really the case.
Okay, thank you.
And with that, we needed to draw this to a close. Thank you very much, Dr. Compton, for sticking around for those last few questions. And I want to thank you very much for that great presentation and all those good story ideas and resources that you had in there.
You're always welcome to contact me or my colleagues at NIDA. We have a wonderful press office that will be happy to arrange interviews with one or more of our local subject matter experts.